Well, let's go ahead and get started. Thank you again and welcome again. You are here hopefully joining us for our webinar Up to Our Neck in Autoimmune Thyroid Disease, a lifespan look at women's health. I'm Katie Schubert. I'm president and CEO of the Society for Women's Health Research, which is a national nonprofit dedicated to advancing women's health through science, policy, and education while promoting research on sex differences to optimize women's health. And we are just delighted and so pleased today to have three distinguished panelists joining us for the event. We have Dr. Deepa Kirk, clinical professor of medicine in the Division of Endocrinology at the University of North Carolina School of Medicine. We have Dr. Patricia Vugan, professor of pediatrics at Columbia University College of Physicians and Surgeons, and Dr. Layla Lohman, who is an autoimmune disease patient and advocate. I'd like to also thank the sponsor of today's event, Johnson & Johnson, noting that SWHR maintains editorial control and independence over our program development, content, and work products. And as always, the interactive part here, we are live tweeting today's event. We always do this. We would invite you to do the same. You can use the hashtag SWHR Talks Autoimmune on all of the social media channels. And with that, I will turn it over to Dr. Irene Aninye, SWHR's Chief Science Officer, who is moderating today's event. Irene.
Thank you so much, Katie, and welcome everyone. When your body's immune system mistakenly attacks its own healthy cells as germs or foreign bodies, chronic inflammation and tissue damage can lead to the development of an autoimmune disease or condition. Sex hormones such as estrogen, progesterone, and testosterone play unique roles in the body that contribute to differences between men and women concerning autoimmune diseases. Affecting more than 24 million Americans, 4 out of 5 autoimmune disease patients are women. There are more than 80 characterized autoimmune conditions that affect almost any cell, tissue, or organ throughout the body. Among the most common autoimmune diseases are autoimmune thyroid diseases. These can impact women throughout the lifespan and are diagnosed as early as in adolescence, during pregnancy, and even postmenopause. Today, we have brought together 3 experts who will share their professional and personal expertise as we engage in this important discussion about autoimmune thyroid disease and the impact on women's health across the lifespan. Following the speaker presentations, I will moderate a discussion with our panelists, so we invite you to use the Q&A function to submit questions throughout the event. We will try to address as many questions as we can during this program, focusing on submissions that cover recurring themes or questions with broader applicability to the audience. And so with that, I am now introducing Dr. Deepa Kirk to talk about autoimmune thyroid disease and its impact and disparities in women's health. Thank you for joining us, Dr. Kirk. If you can turn on your camera and we will get started.
Fantastic. Thank you so much, Dr. Nye and Katie, everyone who invited me here today. And it's really a pleasure to be here as part of this really unique and amazing community. So I was tasked with giving a brief overview of autoimmune thyroid disease. I am an adult endocrinologist, so much of my talk will be from that perspective, and you'll hear in more detail about thyroid disease in children and adolescents from Dr. Vugan a little later. Next slide, please. So these are the different areas of overview we'll go over. And at the end, I just have 2 slides touching on various impacts and disparities in women's health specifically. Next slide, please. There are overall 2 main types of autoimmune thyroid disease. There is autoimmune thyroid disease resulting in hypothyroidism or underactive thyroid. It's known often as Hashimoto's thyroiditis after a Japanese physician, Dr. Hashimoto, in the early 1900s, who was able to see some of the effects of this disease under the microscope of women with thyroid disease. About 4 to 5% of the US population has autoimmune hypothyroidism in the US, at least of the adult population. Much of this is mild, thankfully, because we can diagnose it fairly early these days, but not all of it is. It is the #1 cause of underactive thyroid in our part of the world. Certainly surgical reasons, radiation, medications. There are many other reasons to develop underactive thyroid, but autoimmune disease is by far and away the most common. And as mentioned earlier, it is a very common autoimmune disease. It is among the most common, if not the most common autoimmune disease out there hypothyroidism. On the flip side, autoimmune thyroid disease can also result in hyperthyroidism or overactive thyroid or excess production of thyroid hormones. It's known as Graves' disease, again, after a physician, Dr. Robert Graves, I believe in the 1800s, who first described the condition. While it is less frequent than hypothyroidism, it is certainly not rare. It's seen in primary care physicians' offices as well as endocrinologist's office. Up to 1% of the population may have overactive thyroid. There are many other causes of overactive thyroid, but still Graves' disease, the autoimmune version, is the most common, especially in young women and people in their 40s to 50s. Next slide, please. So the autoantibodies that are the cause of autoimmune thyroid disease can be measured for part of diagnosis. In hypothyroidism, the antibodies mediate destruction of the gland over time. So it's a continuum. It doesn't happen all at once. People can carry around autoantibodies for years or even decades before there's any manifestation of disease. Often up to 80% of the gland must be destroyed before hormone levels fall to a clinically detectable range. And on the other hand, for hyperthyroidism, there are antibodies that specifically stimulate the thyroid gland to make additional thyroid hormone. And that is the basis for Graves' disease. Next slide. As alluded to earlier, women are at a much higher risk of autoimmune thyroid disease. The vast majority of cases occur in women, but remember we mentioned how common this disease is. So hypothyroidism of an autoimmune nature is extremely common, not just in women, but in men and people of all ages. It's just that women are disproportionately affected. Next slide, please. So what are other risk factors besides female sex? Age is a very common one for autoimmune hypothyroidism or Hashimoto's. The prevalence just increases throughout a lifetime. So if you were to survey through labs a population of women in our part of the world over 70 or 80, up to 15, 20% of us may have evidence of autoimmune hypothyroidism. For Graves or hyperthyroidism, there's a little bit more of a bimodal distribution, meaning it's most common in women who are younger, 40s to 50s. And as we get older, although I have diagnosed people with Graves' disease even in their 80s or 90s, other common causes become more prevalent. If you have another autoimmune condition, such as childhood or type 1 diabetes, lupus, rheumatoid arthritis, you are more prone to developing autoimmune thyroid disease. And then the one thing that's still a bit of a mystery is in people who are genetically predisposed, what is it that triggers the development of the clinical disease? It's probably something environmental, like with many autoimmune conditions. There's genetic predisposition plus environmental impact. Interestingly, iodine excess can trigger both underactive or overactive thyroid, depending on your gland's predisposition. Other things like external radiation, certain viral infections, which can cause inflammation of the thyroid. There are many medications that we use that can trigger people to develop autoimmune thyroid disease if they have a predisposition. And for this seminar, I think it's really important to understand that any changes in sex steroids, pregnancy is often a time where women need more thyroid hormone. And if their gland cannot do that, if they don't have enough reserve, that's the first manifestation of hypothyroidism for many women. After delivery, we see a lot of new thyroid disease as well in people who are predisposed. Next slide, please. The symptoms of autoimmune thyroid disease are largely the symptoms of underactive or overactive thyroid. So very generically and simplistically, hypothyroidism results in a generalized slowing of the entire system. Remember, every cell in the body is affected by thyroid hormone. So if you do not have enough thyroid hormone, common complaints we hear are fatigue, unexplained weight gain, difficulty with concentration and memory. Some people describe that as a brain fog, constipation, feeling cold all the time, having dry, puffy skin. These are all very common complaints in people with untreated hypothyroidism. I've listed some other things there that are not in boldface, but are still something we frequently encounter. With hyperthyroidism, it's the flip side. It is just a generalized speeding up of all the cells and organ processes in the body. People often complain of feeling jittery, losing weight without meaning to, even if they're eating a lot, very anxious, irritable. Sometimes they're misdiagnosed as having a primary mood disorder if thyroid levels aren't checked in time. I think probably the most frequent thing I hear is my heart's racing, pounding. That was the first thing a lot of my patients noticed. Tremors, feeling sweaty, hot, having frequent stools, not necessarily high volume stools like diarrhea, but just frequent loose stools. And periods in reproductive age women can space out. They can become very light, very scant. Unlike when people have untreated hypothyroidism, periods often can become heavy. You can get lots of clots and they can spread out farther. I did put down in the corner of the slide, specifically for Graves' disease, there's another whole set of symptoms that don't necessarily have to do with the fact that you're making too much thyroid hormone. Remember, it's an autoimmune disease that stimulates the thyroid gland, but antibodies in Graves' disease can also interestingly stimulate the fat and the muscle tissue behind the eyes. The eyes are, encased in a very small area, so anything causing extra tissue to accumulate will cause the eyes or the eyeballs to protrude forward, or it can cause difficulty moving the eyes, can cause paralysis of the muscles, can cause a lot of grittiness, tearing. There's a whole host of things that we collectively term Graves' eye disease or thyroid eye disease. And it's an interesting condition because it doesn't necessarily follow the course of the hormone levels themselves and doesn't always improve when you treat the hormone levels. And you'll hear more about that from one of our presenters later as well. But I just wanted to put that on everyone's radar. Next slide, please. The diagnosis, thankfully, in most cases is straightforward. We check labs. We check labs in people who have suspected disease, the symptoms and signs I mentioned before. In the adult world and often in the pediatric world, people who don't have symptoms may be screened just because they're high risk for another reason. For example, my patients who have type 1 diabetes, celiac disease, vitiligo, autoimmune adrenal insufficiency, we screen them yearly for thyroid disease because the chances are they'll develop it in their lifetime. The labs you'll hear about in more detail from Dr. Rugen, but generally it is a TSH and one of the thyroid hormones, T4, which is the main thyroid hormone produced by the gland. There are some other things there that we frequently check. We sometimes will check the other thyroid hormone, T3. It's very useful in people with hyperthyroidism. And we can often check the antibodies that are associated with these two autoimmune thyroid diseases. They can sometimes help with diagnosis, and other times we monitor them to see if the disease course is improving. The latter is more true for hyperthyroidism. I will say for the adult world, we don't usually check TPO antibodies when we diagnose somebody with hypothyroidism because it's just so much, it's so commonly that's the cause over 95% of the time. You don't need it to make a diagnosis. But if you're on the fence about it, or if you're not sure why someone has hypothyroidism, or if you're trying to predict the chance that their mild hypothyroidism may become severe, then there's certainly a role for checking it. And that might be a little bit different in children, which you'll hear about later. Next slide, please. There's not usually much imaging we have to do for autoimmune thyroid disease, unlike in the past. Certainly for hypothyroidism, there's no imaging at all that's recommended. Now, in the course of examining a patient, you may feel an irregular gland or a nodule, in which case you may do an ultrasound. For hyperthyroidism, up until maybe a decade ago, we were very commonly doing nuclear scans with radioiodine to see where the excess thyroid hormone is coming from within the gland. These days, we just check thyroid antibodies. If they're elevated, we know the person has Graves' disease and we don't have to subject them to another complicated, expensive test. But in some cases, we still do it to make sure there's nothing else going on, like an overactive nodule, for example. Next slide, please. Treatment is also, at least on paper, relatively straightforward. For hypothyroidism, we will replace what's missing. Thyroxine is the main thyroid hormone that comes out of the human thyroid gland. Luckily, we have a synthetic form of that called levothyroxine that we can give women, and then with the disease, and adjust it according to lab levels every 6 to 8 weeks or so. I've listed a few other treatments that we sometimes use for patients who don't feel well or who do well on the standard levothyroxine treatment alone. That's a little more complicated discussion, but I list it there just so you know it's sometimes used by endocrinologists. For hyperthyroidism, we have a number of options. We can use medications, which is usually first line, to reduce thyroid hormone levels. Some people will go into remission and can come off of medicine. There are definitive or curative treatments. Therapeutic iodine and surgery will obviously cure the condition and will render people hypothyroid. And then lastly, for that thyroid eye disease I mentioned, for many, many years, it was really difficult to manage. Our ophthalmology colleagues did the best they could with high-dose steroids and surgery and all sorts of other things. And a couple of years ago, thankfully, we had the first FDA-approved medication for this condition. It's a monoclonal antibody that's infused every couple of weeks for 6 months, and it can be very helpful for patients with this condition. Next slide. Okay, so I have 2 more slides to go. So let's go on to the impact slide throughout lifespan. So I've just listed out here the various ways that autoimmune thyroid dysfunction can affect a person, specifically a woman, throughout her lifespan. You'll hear more about childhood and adolescence soon. I will point out that the reproductive years, I think, can be really challenging for people. These are times, whether or not people choose to have children, those years are times where people are in school, they're working, they're building a family, they're building a life, they may or may not have insurance. And there's a lot of ways it can be challenging to manage your thyroid disease. It can affect your fertility. Once you become pregnant, it can increase your risk of certain complications. We see a lot of women for the first time postpartum, about 6 to 12 months later, is a very common time for someone to first be diagnosed with Graves' or Hashimoto's. And then more and more, my personal practice deals a lot with women who are at what they call the perfect storm of perimenopause, postmenopause, and thyroid disease. Weight gain, mood problems, metabolic complications like diabetes and fatty liver, all of these things can occur in the midlife. And then finally, in older age, people who have traditionally even done well on their thyroid medication, we just have to be a little bit careful not to overtreat and not to make thyroid levels too high. It can affect their cognition, falls risk, bone disease. Sometimes they can get lost in the mix, particularly our frail, complicated elders are on many, many medicines. So sometimes the thyroid gets forgotten until we realize that it needs to be adjusted. Last slide, please. And then this is a slide that probably deserves a lot more discussion, but I do think it's important to put out there can be a lot of disparities for women's health in the thyroid field. Because we have labs, it makes us quite fortunate, unlike other hormone conditions where labs alone are not always the way to make a diagnosis. We erroneously think that fixing the labs themselves will always fix everything. Many times it does. 80-85% of the time, if you can get someone's lab stable, they will generally tell you they're feeling well and they're happy with their care. But that's not true for everyone. Many people have lingering symptoms, more so in women than men. Whether it has to do with sex steroids or other issues, we're not entirely sure. Maybe we're not replacing everything the woman is missing in the case of hypothyroidism. And, we haven't really had any new treatments since the 1940s or 50s for many of our thyroid conditions. There may be other things that are missed if you assume everything is due to the thyroid. I've seen a lot of undiagnosed sleep apnea, depression, other autoimmune diseases. So important not to lose focus on the whole person. And then I mentioned earlier financial impacts. That's true, obviously, of any chronic condition, but I think sometimes thyroid is a little bit of a silent condition. People don't realize how much you can accrue in terms of quality of life issues and financial impact. So with that, I'll end my part of the presentation, and I think we'll take Q&A at the end.
Yes, thank you so much, Dr. Kirk. Please note to those we're getting some questions that are being submitted. And to those who are tuning in live, you can submit your questions using that Q&A function. So next we will have Dr. Patricia Vugan, who will discuss how autoimmune thyroid disease is diagnosed and treated and the different options to manage disease with a focus on adolescents.
Thank you so much for this invitation, and let me share my screen. Give me 1 second. Is that okay?
You have to revert. Yes, there we
Perfect. Okay, so I'm just going to talk about autoimmune thyroid disease, mainly in the pediatric population, because I think there is some difference when we think about children. And the way that I want to focus the presentation is on the top, it's going to talk about hypothyroidism or low thyroid, slow thyroid. And in the bottom, I'm going to talk about hyperthyroidism or speeding up. Okay, very, very active, hyperactive. Now, what happened in pediatrics? A lot of the times I get referrals because the patient has problems with their weight. COVID can gain 20 pounds, 30 pounds, 40 pounds. And the first thing that the parents want to know is this is a thyroid problem. So here on the top, we can see a patient who was before the diagnosis of hypothyroidism and while she was diagnosed with hypothyroidism. So somebody will say, yeah, so if you're hypothyroid, that means that you're gonna gain a lot of weight. But the caveat here is extremely important, is you do gain weight, but at the same time, and this is extremely important, you stop growing. So if you look at what it is, a growth chart in a pediatric patient, and on the top, you're gonna see the height, and on the bottom, you're gonna see the weight. You're gonna definitely see some weight changes, maybe 10 pounds, 20 pounds. But the most important thing, you stop growing. So weight gain and lack of growth, number one thing is to think about thyroid disease. So obesity itself is not a cause secondary to hypothyroidism. Actually, we know that in kids, if you are overweight or obese, your TSH tends to be higher. And that higher is because there's supposed to be a resistance to a TSH. So a kid who's overweight can have a TSH level between 5 to 7.5 and considered normal. So again, weight gain and lack of growth, number one indication for an evaluation of thyroid disease. The opposite is true also for the hyperthyroidism, that in this case is speeding up. So it's very common to see hyperthyroidism in pediatrics that presents with an enlarged thyroid gland. Okay, it's more common in pediatrics to see an enlarged thyroid gland than in adults. And at the same time, the patient in this case is growing like a weed, very, very tall. So if we look, I mean, this is not the greatest picture, but if you look again at a growth curve of somebody with hyperthyroidism, you have very, very, very rapid growth. So rapid growth, the presence of an enlarged thyroid gland, sleeping difficulty, poor school performance, extremely important. You have a patient who was A's all the time and becomes a C student, you have to think of a thyroid disease. Now, how do you make the diagnosis? And the diagnosis is very similar to adults. You measure what is called the TSH. So again, on the top, hypothyroidism, in the bottom about hyperthyroidism. For hypothyroidism, everything slows down and your TSH goes high. And the other things that we do in pediatrics, we do measure the antibodies because, again, you can have some other causes of hypothyroidism, and I'm going to touch that in a minute. And you also look at the free T4 and TSH. And occasionally you can do a thyroid ultrasound, especially for hypothyroidism, if when you're examining the patient, you're feeling that the gland doesn't quite feel right, was just a little enlarged. So we try to be a little more careful in pediatrics and do a thyroid ultrasound. Now, we have a lot of patients that come to us because they have elevated thyroid TPO antibody. TPO antibody is increased, but it had normal TSH level. We usually tend to follow those patients every 6 to 12 months because we know that in pediatrics, by having an increase in TPO antibodies has an increased risk to develop thyroid disease by 3.5-fold. Okay, so again, TPO, even though tend to be very common, positive in the adult population, if you're in a pediatric patient, you tend to follow because at some point you could potentially develop hypothyroidism. For hyperthyroidism, remember, speeding up, everything is very fast. You pretty much measure the same thing, a TSH, and the TSH tend to be low, sometimes very low. If when you examine, again, the examine of the thyroid gland is extremely important because you have to feel it, you have to make sure it's not enlarged, that's having nodules. So if you're examining the thyroid gland and you're not sure about it, usually it's recommended to get an ultrasound because sometimes you can have what is called a thyroid nodule, and that is the cause of hyperthyroidism. And by removing surgically the nodule, you pretty much are cured. Now, we do not treat TSH levels. Okay, I have plenty of patients that come to me and gain 10 pounds. You have a TSH in a 4 or 5 range, they want treatment. We do not treat a TSH level. We treat the patient, the whole picture, because some things can really change your levels. For example, age. In children, we know that the TSH tend to be higher. Pregnancy can also alter your TSH level. Medication, birth control pills, very common. I had a patient of mine who came the other day for the first time. The patient is gaining weight. You have to do the thyroid function, and did the thyroid function. Everything was perfect. So I called the mom and I said, the thyroid is normal. And then she says, no, they're not. The T4 level was very high. And the T4 level, actually, because she was able to look at the labs, was high. And I said, is your daughter on birth control pills? And she said, yes. So the T4 level was high just because she's on birth control. So it's extremely, extremely important to know what type of medication the patient is on. So you have to be very careful when you're interpreting the results. We do not treat TSH levels. So here are some of the things that have been associated with alteration in TSH levels. Smoking drops your TSH level. Overweight, obesity, increase your TSH levels. Exposure to iodine, zinc, selenium, all those things, alterations in your diet can also alter your TSH levels. So you have to look at the patient by the symptoms, the medical history, think about imaging, exposure to medication, and then make a decision if you want treatment. Now, in pediatrics, again, on top, I'm going to talk about the hypothyroidism treatment. In the bottom, I'm going to talk about hyperthyroidism. In pediatrics, we're a little more liberal. We don't look for a TSH that it has to be less than 4.5, 4.6, depending upon on your assay. We are pretty happy if your TSH is within up to 10. So if the TSH is greater than 10, probably the recommendation consistently, not one blood test, so consistently above 10, at least 2 or 3 times you measure is still 10, or definitely has symptoms, and you have low thyroid hormone levels, that will be a no-brainer. You start your treatment. But if you have a TSH between 6 and 10, you just wait. You see what happens. Is the patient having symptoms? Is that TSH getting worse as you repeat? In that case, you may decide to go for treatment. And usually what we use is T4 or thyroid hormone replacement. We don't use in general T3 for treatments, and we don't use Armour thyroid. One of the things that you have to remember that the life of the treatment, every pill can stay in your system for 7 days. So if you skip the dose once every few days, probably is fine. It's ideally not to take it with anything, with an empty stomach. It's a little difficult in pediatrics because most of the time the kids are rushing in the morning and they're having breakfast before going to school. But you cannot take it with iron, not calcium, aluminum, and some kind of medication. Ideally, again, as I said before, early in the morning with an empty stomach. And the dose tend to increase, or you need more medication during stages of puberty because of all the hormones and the growth, and during pregnancy. And most of the time, hypothyroidism is a lifelong condition. Now, for hyperthyroidism, it's pretty similar to treatment compared to the adults. The only thing is we do not use what is called PTU, because we know in children have been associated with acute liver failure. So none of my patients currently on PTU. We stopped using PTU probably around 15 years ago. And the other thing is, it's around 30% of the patients can go in remission after 1 or 2 years of treatment. And also we have surgery or radiation are possible long-term options for some of the patients in which we cannot use medication. Now, as Dr. Kirk mentioned, we do screen patients with autoimmune disease for thyroid, specifically type 1 diabetes. We have a lot of, as you know, pediatricians, we have a lot of patients with type 1 diabetes, and every patient with type 1 diabetes gets screened for thyroid once a year. The same thing if you have a patient who has hair loss of alopecia, you're a teenager, you're going through puberty, you start having hair loss, that will be an indication for check for thyroid. Celiac disease, each celiac patient is supposed to get a thyroid test done. And then other issues that we don't see so much in pediatrics, such as fibromyalgia, presence of joint pain, inflammatory arthritis, any rheumatoid arthritis, lupus, etc. Those are indications for screening for thyroid. And one of the things that we also do is, like, we do know that it's increased risk for thyroid cancer in the pediatric population. We don't understand why, but it is an increase. So somebody who has the condition for many years and has some kind of abnormality on the exam, we tend to do ultrasounds to rule out thyroid cancer because there is a connection of increased risk of autoimmune disease and thyroid cancer later on. Now, what are the new things out there for thyroid disease? In general, again, as I said before, you have to look at the whole picture. Extremely important. You know, we talk about the environment. Well, how's the diet? For example, I have a patient of mine who was autistic and had a very, very limited diet, and came to me because of normal thyroid tests. And then when I started asking questions, the patient was eating only 2 or 3 things. And I measured iodine in the blood, and it was very low. As soon as we supplemented the iodine, the thyroid test normalized. So again, look at the environment. Is the patient exercise, smoking? There's an association of vitamin D deficient also in thyroid disease. So we are measuring vitamin D on those patients. It's very easy to do TSH, and most of automated assays that will give you a pretty accurate TSH level. And molecular analysis of genetic testing is mainly for thyroid cancer at this point, even though we know that if a parent has thyroid disease, there are 4 to 6 chances that the child will also have some thyroid disease. And the treatment, as I said before, in pediatrics, we use T4. It's in tablets. Again, remember early in the morning fasting. But if there's issue with absorption, you can also start using the liquid solution. Now, sometimes it's not paid by insurance, but it gets better absorbed. The same thing, if there's issue with absorption, you can use gel capsules. We do not use, in general, L3 formulations. There is a push to start using selenium to decrease autoimmune disease. The literature in the adult world that it talks that the patients who are not treated well with medication, they may consider thyroidectomy or removal of the thyroid, but we don't do that in pediatrics. So far, there's no treatment with immunotherapy, even though it has been tested. Question about metformin, again, is out there, but it's not been proven to improve autoimmune disease. Stem cell therapy, and what is called tiratricol, that is thyroid hormone analog, that again has been pushed, but we don't use in pediatrics.
Thank you so much, Dr. Vugan. And I would now like to invite Dr. Layla Lohman, who will discuss her personal experience as an autoimmune thyroid disease patient. Welcome.
Hi, everybody. Thank you. I'm going to share my screen with you. My name is Layla Lohman, and even now, after living with thyroid eye disease for 27 years, I learned something new from Dr. Vugan and Dr. Kirk. So my timeline was in 1998, I was diagnosed with Graves' disease and exophthalmos, which is the protrusion of the eyes. And actually, I was taking 13 pills of PTU a day after hearing Dr. Vugan. It actually stopped working. And 2 years later, at 12 years old, and I was getting bilateral bruising, and my two options back then were surgical and or radiation. And radiation for me and my family was not an option, as I was being bullied a little bit, being called bug eyes at 12 years old. I'm also an Iranian American, so when we originally thought that I just had big, beautiful brown eyes, we thought it was due to my descent. Um, the misconception back then is it got fixed after surgery. And I believe it's because after hearing both these doctors, it's awareness and education and lack of understanding. And I think that it's so important in webinars such as this that the patient voice is heard and the patients need to be educated. But in general, it becomes a provider, patient, caretaker, and all the supporters who help those people to deliver the awareness and education. On the lower right side, I was very frustrated about being bullied that when I got my thyroidectomy, and you can't see the scar, but I decided to put bright blue eyes to kind of say, hey world, my eyes might be big, but I'm not gonna let you make fun of me. And it was a very emotional time, actually, looking at hindsight. Living with Graves' disease and what now is called thyroid eye disease was a lot of struggles. I have a twin sister on that upper photo that I had such an extreme case of thyroid that they decided to check her, and she was slightly hypo. I was bullied. I had undiagnosed pain and was considered lazy to not enjoy being going outside, when I didn't realize that the ultimate other problem was that my eye condition may have never been fully addressed because the protrusion had been resolved based on my thyroidectomy. And
Dr.
so, yes.
Your slides are not showing, so I just wanted to
Oh,
check.
uh,
Sorry to interrupt.
no, that's okay. I don't know what happened. Okay, let me get out of it. I apologize. It worked when we tried this. Let me get it real quick. I apologize about the inconvenience.
No worries.
And let me go to share screen. Can you see it now?
Yes, we can.
Okay, I apologize about that. So
Oh.
there I am. And then there's the blue eyes, and here's myself and my twin. So going back to it, I realized in 2000, I had a thyroidectomy and we all thought it was fixed. And then in 2015, I was pregnant with my son, and I started getting eye pain, double vision, went to multiple providers, and they told me I am in an acute phase of thyroid eye disease. And I laughed in their face because I said, no, I don't have any thyroids. And no one really explained that you still can have an autoimmune condition in the eyes. During my pregnancy and family planning journey, it is very important to, when you get pregnant as a female, to be checking your levels, because there was multiple miscarriages. And if providers aren't aware of this situation, it doesn't really help the patient in the emotional journey of living with this condition, as well as trying to family plan. And that's one of the reasons I became a patient advocate, was to share my story. So fighting for treatment during my pregnancies was very challenging. Even though I was in my 30s, I'm a healthcare professional. It's still misunderstood by doctors, where my condition was worsening, but my kids were okay. And I had to fight to explain that if my child is healthy, I'm going downhill. I need somebody to make a decision to get my baby out healthy, advocate for myself. And no one wanted to take, I would say, the risk of deciding who's supposed to be healthier, me or the child. So I fought for myself. And as soon as I had the C-sections, my condition resolved itself by 70%. And so imagine living like the photo on the lower right side for months in on itself, and still trying to be healthy for my kids. So you have to self-advocate. The turning point for me was I was treated conservatively by my providers with education and awareness of myself. And in 2020, there was the first FDA approved medication to treat thyroid eye disease at the source of the condition instead of symptomatically. And mid treatment, it was due to the pandemic where many biologics on the market, including mine, had a disruption of service. And so I had a 4-month gap in my service distribution of medication. And I became an advocate because I could not understand. I'm 6 inches away from patients' faces. And so I am a huge proponent of vaccines, but to disrupt medications that are life-changing is not fair. So in 2020, I became an advocate due to that disruption. Navigating medical systems and medical insurance is a very complex procedure. And I had many people like patient access liaisons and the Society of Women in Health Resources and Research. All of these people and supporters were helping individuals like myself to figure out and navigate the system based on that disruption. I will tell you the amount of relief I felt after taking that biologic was life-changing. I didn't know what normal felt like until I had the relief. And so living with that disease for over 20 years, thinking it's normal to constantly feel like you have an eyelash in your eye or sand in your eye, and never realizing nobody else feels like that is been liberating, including different avenues that I've been taking for personal therapy and art therapy. So, my story is to give hope to others, advocating for yourself, being around individuals who help build you up. But also, one of the main things I have learned, especially over the last 4 years of my own learning journey, is myself, my awareness of myself, and being able to speak to my spouse of 20 years and my patients of over 14 years, and speak clearly that I'm not okay and it's okay to not be okay. And normalizing that we can be open and honest and transparent about things without the fear of judgment, or blaming and defending ourselves. And it's through avenues like therapy, psychologists, art therapy program through Prevent Blindness. There's also an empowerment program called Aspect that has helped with patient engagement and advocacy. There's so many people out there who want to support us in being aware. And Dr. Kirk and Dr. Vugan, had I been able to have them as providers, I may have been able to avoid this after 20 years and been more empowered at a younger age. So in the thyroid eye disease community, I am helping build the TED-Co community through hosting educational webinars, because as a healthcare provider, as a patient, as a mom, as a wife, as a human, we need to make sure we're supporting each other and not competing with each other, because the best version of yourself is somebody who cares about themselves and gives themselves the same grace as we give our family and friends. So motivation is a huge part about that. And that is my journey, and my why is my 2 adorable children and my husband, and empowering others. Sorry, I didn't even think I was going to get emotional about this, but hold on, I'm going to take a breath. It can be very lonely and isolating living with any chronic health condition. So sharing your story and inspiring others is my why. So thank you for having me.
Thank you so much, Dr. Lohman, and everyone for setting the stage for this panel discussion that we will, we have another 10 or 15 minutes to do. And, as you talked about your experience, and even towards the end, we appreciate the vulnerability. And, this is why we have these types of forums, so that individuals can learn what are the challenges, if they're researchers or healthcare providers, so they can start to address them. And if they are other patients, they can be empowered by them and recognize that they are not alone. And so I see all your videos are on. I think, Layla, you're still sharing your screen if you want to pull that off. Perfect. And at this time, again, attendees that are live, you can submit questions using the Q&A function through the webinar app. And please note that our conversation today is intended for educational purposes and not intended or implied to serve as a substitute for medical or professional advice. We encourage all patients, caregivers, and listeners to confirm information and consult with their healthcare providers to determine their individual needs. And so to open this conversation, I wanted to maybe, Deepa, if you can talk about what came up earlier was mentioned are factors like birth control pills that can affect hormone levels. And so these are some of the factors that affect TSH, thyroid hormone levels. Are there other gender related differences in reference ranges when considering that throughout the lifespan and through adult, or interventions or treatment outcomes that we see that are different between men and women?
That's a great question. At this point, there are not specifically different reference ranges between men and women for thyroid levels. There are many studies that have done looking at this in various populations, and in general, women may have just a very slightly higher TSH than men, maybe 0.2 to 0.3. Remember, our normal TSH is generally between 0.5 to 4.5 on most lab reference ranges. Understanding the individual goals may be more specific. So really not much different gender-wise when it comes to those levels or interpreting levels. But as Dr. Vugan mentioned, there are so many other things that go on in women's lives that affect how we interpret those levels. So many things can affect the TSH and make it, quote, high or low that have nothing to do with your thyroid being dysfunctional. And so you can really do just someone a disservice by inappropriately labeling them with a disease they don't have and barking up the wrong tree. And that is definitely more common in women than men. I get a lot, Dr. Bergen, of referrals for the same reason from OBs, really wanting to be on top of things, wanting to have the best possible pregnancies for their patients, some of whom do have thyroid disease, but many of whom it's literally just a lab abnormality. I'll tack on very quickly, though, the reference range issue is important. We're hoping in the not too distant future that reference ranges across the age span in adults will be more specific. We do know that older, healthy adults typically on average have a higher TSH than middle-aged or younger, healthier adults. So this some call an epidemic of finding hypothyroidism in healthy 70, 80, 90-year-olds. Again, we may be doing them a disservice by treating them with thyroid medication they don't need. So we know that's true. We don't have those lab reference ranges readily available commercially yet.
Thank you. And Dr. Vugan, you talked about, you work with adolescent pediatric patients, and I'd imagine some that go into adolescence in maybe their teens, early 20s before they transition into adult endo. And do you see trends when it comes to remission, or is autoimmune thyroid, is that something that can be achieved on its own with medication? What is a reasonable expectation for young girls and women as they age?
That's an amazing question. In general, the rule of thumb is if you have hypothyroidism with positive antibodies, autoimmune hypothyroidism, the chances are that you're not going to go into remission, even though I did have a handful of patients in which they became, completely euthyroid. In general, what I do that may not necessarily be what everybody does is I try to do the antibodies once a year to see where they are, but the antibodies tend to fluctuate. So they go up and down, up and down. You had a virus infection a week ago, your antibody is going to be sky high. But I have seen very rarely minority in which the antibodies completely disappeared. And in those patients, I try to wean off the medication and stop. But again, that's the minority for hypothyroidism. Hyperthyroidism, the rule of thumb is around 30% go into remission, but I had patients that went completely into remission, 0 antibodies for Graves, a year to 2 years later, came back. We don't know what were the triggers. People talk about stress, number one, supposed to be, especially adolescent, taking tests, going into college. So even though you maybe have been labeled cure, like Leila was saying, you have to remember that once in a while, once a year, you have to go to your endocrinologist to monitor.
I can be very fortunate to say that I'm probably one in that 30% that achieved remission and have been in remission. I had Graves' disease diagnosed when I was a teenager. So, and Layla, I want to pivot to you as well because if, the expectation of remission, it's a chronic condition, there are lifelong implications. As you mentioned in your particular story, while your thyroid was treated, you had, you know, other health conditions, you had TED that you still dealt with decades later. Can you kind of speak to the significant, like emotional and even maybe the social burden that comes with having a lifelong chronic condition? And what are some of the key considerations for managing um, mental wellness and impacts during, your journey?
That was a long question. So if I missed it, you gotta do it. But the social burdens for me, I think it was very difficult in 1998 when it wasn't as more commonly known. Just like Dr. Vugan was saying that like they stopped using PTU 15 years ago, and I was on that medication for 13 pills a day. And so the social burden is you're growing up in a world that people are not kind. And we try, like we all who have children try to raise kind humans, but you can't help when they're trying to learn their own learning journey. So the social burden is something that if females specifically can build confidence and not competition, it will help us all living with most people have some condition. Mine is just thyroid eye disease and Graves. And so my social burden came from, I mean, luckily I had a twin. She was my best friend, so I did pretty good in the friend game. But being made fun of and being called lazy and not enjoying outside, I still deal with it with my son today that I don't enjoy going outside because my condition is not cured. I still have the acute phases and the chronic phases, and it's hard. And that's where normalizing mental health and that your spouse can't be your psychiatrist or psychologist and your best friends can't be either because there's a bias in anyone who loves you. And so I find it very hard for people to say, I don't want to go somewhere else. But I just challenge you to say, go be authentic to somebody who is not, that knows you, and they will help advise you on how to help yourself be that person. So even if society keeps calling me bug eyes, I would be walking in the grocery store and I'm like looking at something and my eyes would protrude out and they'd be like, you've got the most beautiful eyes. And inside I die. Like, right. Like this is like my scarlet letter and they don't know that. And so I've realized over the last 5 years that I can't let them decide my emotions. And so now I invite people to just ask questions. And when they say something, I'm like, oh, I have thyroid eye disease. And it might make them feel awkward, but it doesn't make me die inside when people say it. And it just helps me learn how to talk about my condition in a constructive way and not a self-limiting way. So I think that kind of answered your question. I don't remember the last part, but I believe in the last 5 years, empowerment through self-awareness and self-advocacy and education has been the biggest positivity in my life.
Thank you for that. And so, Dr. Kirk, Dr. Vugan, if you can briefly, if either of you have a comment to the role of environmental or toxin exposures when it comes to autoimmune thyroid disease in particular. What do we know about it? What are we still missing? Or um, and then is there an area that you want to highlight and say this should be where the research goes?
Yeah, I'll start if that's okay. I think this is really an area that a lot of people have concerns and questions about. There are some things environmentally that we know affects the thyroid. These are the very rare, huge things like nuclear disasters. We know around Chernobyl, we know around in Japan, we know people suffer huge rates of thyroid dysfunction, thyroid cancer, and we know the biological reasons for that. And I think I saw in the chat somebody asked about Agent Orange, herbicides. There are so many different environmental things that can trigger extra autoimmunity or autoimmunity turning into a clinical condition. And we don't know the individual thresholds. The studies that, as far as I'm aware of, the studies are not there as to how much an individual person would need to be exposed to develop disease. Obviously, we hope for zero exposure. And then I saw another great question in the chat about products, beauty products, hair products that may be used by women, especially Black women. There's a lot of interest in that recently. Relaxers and things that were used decades ago being linked to autoimmune and many other conditions. And I think there's more and more credence behind that. There has been studies from NIH researchers. So the short answer is absolutely there's things that are affecting the thyroid. The short answer is it's very hard to give individual people advice in the office. Unfortunately, I'm in the situation where I'm just seeing someone once they've developed a condition. But what can we do for awareness? We certainly can talk about exposure products that have a higher link of risk of developing autoimmune thyroid disease, and just continue pushing for research. The vaccine question is always there. I saw that in the chat also. Any vaccine, its job is to trigger your immune system to fight disease. So could there be innocent bystanders where the immune system accidentally triggers an organ that shouldn't be destroyed? We see that with type 1 diabetes too. People ask me, did my child develop type 1 diabetes because it got vaccines? I can't really answer that. We know the powerful impact and positive benefit of vaccines. And I would always advocate to follow the general guidelines for getting vaccinations. But understanding there may be some people who have genetic susceptibility to where their autoimmune disease may have been triggered by a series of vaccines. I just don't have a definitive answer on that.
So I just want to add that there was a question about vitamin D. Again, it's not known. I tell you based on my experience with my patients, most of my patients are vitamin D deficient anyway, and I treat both at the same time. I measure vitamin D, and I explain the rationale why I do it, because most of the kids have horrible diets, and most of the kids spend most of the day inside and don't go out. So usually my vitamin D gets paid by the insurance if you have a good rationale what you're doing. But I put the patients on vitamin D and I still going to require thyroid. And I really don't have to adjust the thyroid medication while I'm treating the vitamin D. And one of the things that I've been using a lot these days is I asking the parents to increase the amount of selenium in the diet. Like what's it called, Brazil nuts. They have a good amount of selenium. It's supposed to be good for your thyroid. I have some successes, I have failures, and I have nothing changed. Fish is a good thing on a diet anyway, and I try to propose that for pediatrics. And it's not the pediatricians. I mean, maybe we look more at the picture holistically, because we're dealing with a child. I don't want to label a child with a thyroid problem if the child doesn't have it. So I'm going to use every niche resource that I have available to make the right diagnosis. And I think that's the difference between maybe pediatrician and adult.
Thank you so much. This conversation, I wish we could get to all the questions, but I love the rapid fire that you guys gave for some of the ones that had come in that were submitted. And so before we wrap up, I do have one last question. We often have patients and healthcare providers, as well as researchers and policy professionals that tune into our webinars like this. And so what is one takeaway that each of you would recommend to viewers to support women in their journey with autoimmune thyroid disease? And so we'll start with Dr. Vugan on that pediatric end, Dr. Kirk, and then we will end with Dr. Lohman.
I think I get the same message. Look at the whole picture and don't get hung out on what is a TSH level. Because in reality, to be honest, it may not mean anything.
I would really encourage everyone to advocate for research and treatments for thyroid disease. We do okay, and in fact, sometimes we do really well. And as Dr. Vugan mentioned, a lot of times we may uncover things beyond just thyroid disease if you're looking, hopefully, always at the whole patient. But we have relatively simplistic tools, I think, to treat autoimmune thyroid disease, particularly hyperthyroidism. And while there have been in research things that can affect the autoimmunity itself, and not just waiting for the gland to burn out or waiting for the gland to be overactive, that have not come to fruition in clinical practice yet. And many of my patients are anxiously awaiting conditions that can reverse the underlying issue itself and not just, be a Band-Aid after the fact.
The one thing I'd say on the advocacy side is the supporters are people like our doctors and these providers, like both Dr. Kirk and Dr. Lugan and you, Irene. But honestly, on an advocacy level is awareness, sharing your story, doing the therapy you need to do so you can do empowering thoughts like art therapy, prevent blindness. If you cannot be an advocate or if you do not feel confident in your voice, go to the support groups like tedcommunity.org. But also, if you can't do that either, donate for them to be the boots on the ground to share and spread the message, because we will be your voice, but your voice is unique and we want to hear it too. And the loudest voice doesn't always get it, but the ones who keep talking about it start making the biggest impact.
Well put, all of you. Thank you so much. I thank our panelists thank you guys for your time, for your insight, for your transparency. It is very much appreciated by SWHR and I'm sure by all of the viewers that we have. And thank you to Johnson & Johnson for their support of this program and SWHR's autoimmune disease program as well. We have a fact sheet actually about autoimmune diseases throughout the body that captures some of the discussion we had today about autoimmune thyroid disease in women, as well as some other areas. And you can download this and other women's health resources on our website, www.swhr.org. And we also invite you to connect with us on social media, sign up for our newsletter, and register for future events about obesity, endometriosis, heart health, menopause, and other topics. We will send out an email with the recording of today's webinar to all registrants, as well as post the recording on the event's webpage for future viewing. So please be on the lookout for that and feel free to share with others as we continue the conversation with hashtag SWHR Talks Autoimmune. Thank you for joining us.